This recording will cover multiple myeloma. Multiple myeloma is a white blood cell cancer. Normally, mature B lymphocytes or B cells called plasma cells secrete antibodies that fight infection. In multiple myeloma, these plasma cells become abnormal and multiply, making abnormal antibodies called M proteins. This leads to bone destruction, kidney damage, and immune suppression. One way to help remember what's going on with multiple myeloma is to think bad crab. Bone pain, anemia, damage to kidneys, calcium's high, recurrent infections, antibodies are abnormal, and bone lesions. The pathophysiology, or what's going wrong with multiple myeloma, is that the plasma cells are multiplying uncontrollably in the bone marrow. They're crowding out normal cells, and that leads to problems with red blood cells, white blood cells, and platelets. You see anemia, risk for bleeding, and infection with these patients. The key concept is that the M protein is thickening the blood, and that leads to damage in the kidneys. And the bone breakdown occurs due to osteoclast activation. Just remember, we have too many bad plasma cells, which leads to weak bones, thick blood, and low immunity. Bone pain is one of the earliest and most common symptoms of multiple myeloma. It's commonly experienced in the back and ribs. It can lead to pathological fractures, so that would be bones breaking or fractures without necessarily high trauma events. It can also lead to osteolytic or punched out lesions on the bones. Remember, if we have unexplained back pain and unexplained fractures, pathological fractures, we want to think myeloma. The bones break quietly. Even with small movements, we can cause fractures. Some key clinical manifestations for multiple myeloma include hypercalcemia, anemia, and kidney damage. Hypercalcemia occurs from bone breakdown. Remember, the calcium's not in the bone, it's in the blood. That can lead to signs and symptoms of hypercalcemia as well as weakness of the bones. One way to remember signs and symptoms of hypercalcemia is the phrase stones, bones, groans, and psychiatric overtones. Stones would be an increased risk for kidney stones. Bones would be an increased risk for pathological fractures or weak bones. Groans would indicate abdominal GI tract issues, so constipation, nausea, vomiting, abdominal pain. And then psychiatric overtones would include fatigue, lethargy, depression, psychosis as well, that could be caused because of hypercalcemia. Anemia occurs because the bone marrow is going to be crowded and it's not going to produce red blood cells like it should. So we've got white blood cell, red blood cell, and platelet issues. So we'll look for signs and symptoms of anemia, fatigue, pallor, signs and symptoms of white blood cells not functioning like they should, such as increased infection, and an increased risk for bleeding because of platelets not functioning properly. We're also going to watch for kidney function and be on the lookout for kidney damage. The abnormal M protein that's produced with multiple myeloma actually clogs up the kidney and affects kidney function. So dehydration is going to worsen this kidney damage. So hydration is a key nursing intervention for patients with multiple myeloma. Finally, infection risks. We got abnormal antibodies. They're not going to work properly to fight off infection. Common infections include pneumonias, UTIs. So we'll be watching for signs and symptoms of infection. Diagnostic tests can include blood tests, urine tests, biopsies, imaging, other labs. With the serum blood test, it would reveal a M protein spike. So we'd have a high concentration of that M protein in the blood. Also with multiple myeloma, we could see Bence-Jones proteins in the urine. A bone biopsy could show increased plasma cells, x-rays showing punched out lesions in the bones. Labs could show high calcium, high creatinine with the kidneys not being happy, and low H&H with anemia with the red blood cells being affected. Remember, with myeloma, we're watching and we're looking for an M spike, and we're also worried about pathological fractures or bone weakness. The CRAB criteria is frequently used, a mnemonic frequently used for multiple myeloma. The C, again, is hypercalcemia. The calcium's in the blood, not in the bones. We have weak bones. The R is renal failure. The M, protein deposits and clogs the kidney tubules, damaging them. A for anemia. Bone marrow is crowded. Red blood cell production is going to decrease. And B for bone lesions, the osteolytic punched out lesions, and we can experience pathological fractures. Meds used to treat multiple myeloma include chemo, immunomodulators, corticosteroids. We'll also use bisphosphonates, which you learned about when you learned about osteoporosis. They help to prevent bone loss and help to keep calcium in the bone. Other medications include epoetin alpha, which works to stimulate red blood cell production and treat anemia, antibiotics for infections, and pain management. Ultimately, multiple myeloma remains largely incurable, and the best outcomes are seen with stem cell transplantation, although not every patient is eligible for that. So nursing priorities include bone protection. Your patient's at high risk for fractures, so we want to handle them gently and make sure that fall precautions are used at all times. Avoid heavy lifting because they're going to be at easy risk or increased risk rather for fractures of the bones. Next, we need to protect the kidneys, and we make the kidneys happy by hydrating them. So 3 to 4 liters a day of fluid if not contraindicated, and we're going to monitor our kidney labs and our urine output closely. Finally, infection prevention. So fever again is an emergency in a neutropenic patient. We want to have those neutropenic precautions in place for them. So avoiding sick contact, strict hand hygiene, keeping the fresh flowers and raw fruits away from them, and monitoring that temperature because fever is an emergency. So remember, we want to protect the bones, flush the kidneys, and prevent infection. We want to push fluids with hypercalcemia as well. We want to aggressively hydrate the patient. Provider might prescribe loop diuretics to promote calcium excretion, and we'll monitor the patient's mental status. In terms of bleeding precautions, we'll use a soft toothbrush, avoid any invasive procedures, and monitor platelet counts regularly. Remember, pancytopenia, which means low white blood cell, red blood cell, and platelet, occurs from bone marrow crowding. This increases both the risk for infection, bleeding, and anemia. So some review. Nice slide to look at prior to exams. If your patient's having back pain, anemia, and high calcium, think myeloma. Leading causes of death in this population is renal failure, so hydration of the patient is critical to keep the kidneys happy. They're at high risk for fractures because the calcium's in the blood, not in the bones, so we want to treat the patient very gently to try and prevent fractures of the bones. And lastly, a leading complication is infection due to those abnormal ineffective antibodies. Patient teaching. Patient teaching includes reminding the patient to stay hydrated, drink plenty of fluids to make the kidneys happy, and flush out that M protein. Report symptoms such as bone pain, fever, or decreased urine output. Avoid infection and use assistive devices as needed to be able to move safely and prevent pathologic fractures. Some more test reminders. When you think myeloma, think CRAB. Calcium's high, renal failure, anemia, bone lesions. These are frequently tested on NCLEX style exams. You could add the BAD, bad CRAB, to remember bone pain, anemia, damage to kidneys. Remember to flush the kidneys. We're going to be pushing fluids and hydrating the patient to keep the kidneys happy. And remember that they're at increased risk for fractures. This slide is just another overview that can be helpful before exams, if you want to peek over that. And some more important reminders about myeloma, which we've already covered.